Good afternoon, everybody. At the outset, I would like to express my sincere gratitude to the organizers for giving me an opportunity to talk on a subject which is very close to my heart. So, for the next 15 minutes or so, I shall give you a brief and simplified overview of the challenges in the management of monochorionic twin pregnancy. I propose to cover my presentation under following heads. The incidence of multiple gestations has risen rapidly over the past several decades due to the widespread use of assisted reproductive technologies as well as increasing maternal age. As we all know, multiple gestations are associated with an increased risk of both fetal and maternal complications. Monochorionic twins especially may develop unique and potentially fatal complications because of the shared placenta. Hence, they require diligent surveillance and care throughout the pregnancy. The problem areas associated with monochorionic twins, which pose a challenge in managing them that I am going to touch upon in this presentation, are unequal placental sharing, TTTS, TAPS, TRAP, and monoamniotic twins. Unequal placental sharing results when one twin receives a greater share of the placenta relative to the other. This results in selective growth restriction or growth discordance. Filamentous cord insertion is often seen in these cases. Amniotic fluid levels may remain normal or slightly abnormal. Unfortunately, no intervention can reverse the pathology, and hence regular twice-weekly surveillance based on biophysical profile, umbilical artery Doppler, and non-stress test are recommended. This surveillance is required to assess the health of the fetus and to time interventions such as admission, steroid administration, and delivery. Monoamniotic twin is another challenging type of monochorionic pregnancy. Its incidence is 5% of all monochorionic twins. Though it can be diagnosed at a very early period of gestation, still the perinatal mortality rate is very high. This is because of several complications including cord entanglement. There lies the importance of close monitoring of the fetuses with USG and CTG from period of viability. Elective cesarean section is recommended at 32 to 34 weeks period of gestation after injection corticosteroid for fetal lung maturity. Twin reversed arterial perfusion sequence, also called TRAP, whose incidence is 2 to 3% of the monochorionic twins occurs between a well-formed palm twin and a recipient acardiac twin that lacks a heart and other structure. Based on what all structures are absent in recipient twin, it may be acardius acephalus, acardius amorphous, and acardius myelocephalus. It is caused mainly by a large artery-to-artery anastomosis where donor twin pumps deoxygenated blood under pressure to its co-twin. Since donor twin pumps blood for self and co-twin, it results in cardiomegaly and high output failure. The management is based on volume of the recipient twin. There is a formula to calculate the volume. Expected management is offered for a case where volume of the acardiac twin is less than 50%. If the volume of the acardiac twin is more than 50%, the treatment of choice is radiofrequency ablation of the communicating vessels. The prognosis remains poor in cases of monochorionic monoamniotic acardiac twins and acardiac twin with a volume of more than 50%. The twin-to-twin transfusion syndrome, also called TTTS, is a dreaded complication that constitutes 10 to 12% of the monochorionic twins. In this, one twin becomes large with polyhydramnios and another remains small with oligohydramnios. It is said to occur because of the normal vascular communication in the placenta. To understand this abnormality, let's first know what is the normal vascular communication in a monochorionic placental tissue. So in peak A, we can appreciate that there is a single monochorionic placenta which has been shared by two fetuses. In peak B, we can see that there are three types of vascular communications, two superficial and one deep. Two superficial communications are located on the surface of the placenta. These are arterioarterial or veno-venal. Both are bidirectional, means blood may flow from one vein to another and vice versa. These two communications, however, are devoid of capillary bed communication, means blood cannot be oxygenated. Third communication, which is located deep inside the placenta, is an arteriovenous communication wherein blood flows unidirectionally from one twin to another. Most importantly, this communication occurs through capillary bed so that the deoxygenated blood inside the artery may go as oxygenated blood to vein. Now let's focus on peak C. Normally, blood from twin A flows to twin B through deep arteriovenous anastomosis. The extra blood that has reached to twin B from twin A is balanced by flow of blood through superficial communication from twin B to twin A, and nothing happens. This is known as balanced vascular anastomosis. Now let's see what happens in abnormal communication. Over here we can see that though the deep arteriovenous communication is there, the superficial arterio-arterial or veno-venal communications are missing. As a result, blood can move from twin A to twin B, but extra blood cannot be balanced by blood flow from twin B to twin A, as there is no arterio-arterial or veno-venal communication. This unbalanced vascular connections results in overload of blood in twin B and its incident consequences. So what are the consequences? The donor becomes small in size, and hypovolemia causes the release of substances such as vasopressin and renin-angiotensin system that leads to less urine production and consequently oligohydramnios. On the other hand, the recipient becomes large in size, and hypervolemia causes the release of substances such as brain natriuretic peptide and atrial natriuretic peptide that increases urine production. This forms polyhydramnios in recipient sac. As the disease advances, the vasopressin and renin-angiotensin system passes to the recipient from the donor through vascular connection. This decreased urine production in the recipient and excess fluid accumulation in recipient body finally leads to overload, causing congestive cardiac failure and fetal hydrops. So how do we diagnose it? There are two diagnostic criteria. One, presence of monochorionic monoamniotic pregnancy, and two, presence of polyhydramnios in one sac and oligohydramnios in another. Because TTTS affects 15% of the monochorionic twin, Green Top Guideline 51, published in 2016, advises the screening of TTTS by regular USG in high-risk cases is starting at 16 weeks and then 2 weekly. We look for the biometry and maximal vertical pocket and visualization of the fetal bladder. Once TTTS is diagnosed, it is very important to assess the severity of the disease. Quintero staging system classifies TTTS in 5 stages. In stage 1, there is a Oli-Poly sequence and urinary bladder of the donor is visualized and the Doppler study is normal. In stage 2, donor bladder is not visualized, however Doppler study is normal. In stage 3, there is Doppler abnormality noted. In stage 4, hydrops develops in one fetus or both fetuses. In stage 5, there is death of either of the twins. There are various treatment options for TTTS that include expectant management, which is applicable for Quintero staging 1 and 2, laser ablation of vascular anastomosis, serial amnioreduction, septostomy, and selective feticide. However, as per Green Top Guideline 51, TTTS presenting before 26 weeks should be treated by fetoscopic laser ablation rather than amnioreduction and septostomy. For laser ablation, a fetoscope is inserted inside the recipient amniotic sac to identify all vascular communications between two fetuses, followed by photocoagulation of all of them. This functionally separates the placenta into two separate pieces. This is referred as dichorionization of monochorionic placenta. There are two types of laser ablation, selective and non-selective. In selective type, all vascular communications between two fetuses are coagulated, while in non-selective type, all blood vessels crossing intertwin membranes, whether communicating or not, are coagulated. Non-selective type is associated with higher pregnancy loss rate, and that is why the selective type is preferred. Whereas the survival rate of both the fetuses is 50%, the survival rate of only one fetus is only 30%, and 20% of the cases there is complete pregnancy loss. Another option of treatment is amnioreduction. It involves removal of amniotic fluid from the recipient sac. This will reduce the intra-amniotic pressure and reduces the risk of preterm labor. This is performed when maximum vertical pocket is more than 8 centimeter. Amnioreduction does not treat the underlying pathology, and this is likely to require repeated procedure. Moreover, this procedure also has complications like preterm PROM, preterm labor, chorioamnionitis, and placental abruption. Another treatment option is septostomy. This involves intentional puncture of the intertwin membrane, theoretically leading to equal pressure into amniotic sac. But generally, septostomy has been abandoned as a treatment of TTTS as it has no significant therapeutic advantage. Moreover, it may cause disruption of intertwin membrane, resulting in a monoamniotic pregnancy. Other treatment options include selective reduction of the fetus. It may be a reasonable option in certain cases like pregnancy less than 24 weeks with severe unequal placental sharing with marked discordant growth, major malformation, and evidence of brain injury before or after laser therapy. Coming to delivery, it should be conducted between 34 to 36 weeks period of gestation and earlier also if there are concerns. One course of steroid should be given before delivery, and mode of delivery is often by cesarean. Twin anemia polycythemia sequence occurs spontaneously in 3 to 5% of the monochorionic twins and iatrogenically in 10 to 13% of the cases after laser ablation of TTTS. TAPS occurs due to a slow transfusion of blood through very small arteriovenous vascular anastomosis. This leads to highly discordant hemoglobin levels between donor and recipient twin. However, there is no substantial difference between the twins in either size or amniotic fluid volume. It is diagnosed by middle cerebral artery peak systolic velocity. If it is more than 1.5 mom, it suggests anemia, and if it is less than 1 mom, it suggests polycythemia. So what is the treatment? In case where immediate intervention is not required or laser surgery is not an option, close monitoring is required to be done. Blood transfusion to the anemic donor twin is option, but it is temporary treatment that can possibly worsen the condition of the recipient twin with polycythemia. Fetal laser surgery of communicating arteriovenous anastomosis is definitive treatment. However, it is highly challenging because these anastomoses are extremely small. So what is the take-home message? Let's remember that monochorionic twins may develop unique and potentially fatal complications. Thus, it is important to know them and diagnose in time. A diligent surveillance and appropriate interventions may save many such affected fetuses. It goes without saying that most of these cases will need expert care of a feto-maternal specialist and a neonatologist. Thank you, ladies and gentlemen. Thanks for your patience hearing.